Good morning, Srikanth.
Sir, good morning, sir.
Good morning, sir.
ఎక్కడున్నావు గణపతి?
సార్ ఇంట్లో ఉన్నా సార్.
ఇంకెవరిది ఎక్కడో స్నోరింగ్ సౌండ్ వస్తుంది ఎక్కడ?
అదే సార్ ఎక్కడ
బషీర్ అనుకుంటా సార్.
ఎవరు?
బషీర్ ఏమో నిద్రలేపినట్టు ఉన్నాం మనం.
కరెక్టే శ్రీకాంత్, బషీర్ తిన్నట్టుంది.
గణపతి, ఐ థింక్ యూ కెన్ మ్యూట్ హిమ్. నేను కోహోస్ట్ చేశాడు కదా.
యాక్చువల్లీ నేను మొబైల్లో ఆన్ చేశాను సార్, ల్యాప్టాప్ లో ఓపెన్ అవ్వట్లేదు.
నేను మ్యూట్ చేశానులే
ఇందులో. ఓకే.
గణపతి స్టార్ట్ చేశారు, జాయిన్ అవుతాడు.
సార్ మోహన్ సార్ స్టార్ట్ చేస్తున్నా సార్.
చెప్పాను కదా, శ్రీకాంత్ చెప్తే చేసామే, నీకు ఇందాకే చెప్పాను.
శ్రీకాంత్ సార్ అయితే స్టార్ట్ చేస్తామంటారా?
స్టార్ట్ చేశారు.
869.
రాంప్రసాద్ సార్ వచ్చారు కదా, స్టార్ట్ చేశాం. జయరామ్ అనుకున్నాను, సార్ వచ్చారుగా.
Good morning, sir. Today my topic is geriatric anesthesia. I'm going to discuss about geriatric anesthesia in the following subheadings: definition, physiological changes, preoperative assessment, anesthesia technique, anesthesia drug, and postoperative management. Coming to the definition, most of the world countries have accepted the chronological age of 65 and more as definition of the geriatric patient. These patients divided into three groups: elderly patient, aged and very old. Elderly patient aged between 65 to 74 and aged between 75 to 84 and very old, age 85 and more. Physiological changes I'm going to discuss about at cellular level and organ level. Coming to cellular level, with increasing age, there will be decrease in antioxidant and scavenger capacity, which leads to oxidative stress, which causes the increased intracellular free radicals, damage to membrane, proteins, and genetic integrity, and decreased bioenergetic capacity, which causes loss of tissue and organ functional reserve and increase susceptibility to disease, infection, and injury. Finally, cell land up in death. And organ physiological changes in elderly patient. Coming to cardiovascular system changes. With increasing age, there will be decrease in arterial elasticity, which leads to elevate afterload, elevate systolic blood pressure, which causes the left ventricular hypertrophy. Second, decrease adrenergic activity, which leads to decrease resting heart rate, decrease maximal heart rate, and decrease baroreceptor reflex. Third, fibrosis of conduction system and loss of SA nodes, which causes the severe bradyarrhythmias and syncopal attacks. Fourth, decrease cardiac reserve, which leads to decreased exercise tolerance. Anesthesia implication of cardiovascular physiological changes. There will be delay onset of anesthesia when using IV induction because of prolonged arm-brain circulation. These patients are more prone to intraoperative hypotension and bradycardia due to decreased sympathetic activity. And there will be imbalance between oxygen demand and supply in elderly patients more common. It leads to increased perioperative risk of MI and arrhythmias. This patient may poorly tolerate perioperative fluid administration, which leads to pulmonary congestion very commonly. Ejection fraction up to 45% is normal for geriatric patient without any symptoms. Coming to respiratory functions. With increasing age, there will be increased chest wall rigidity due to calcification of costochondral junction. Second, decreased muscle strength, which leads to decreased cough, decreased maximal breathing capacity. Third, decreased pulmonary elasticity, which leads to decreased alveolar surface area and decreased vital capacity, forced vital capacity, and forced expiratory volume in 1 second, and increased residual volume and closing volume and closing capacity. There will be an increase in VQ mismatch, and respiratory stimulation to hypoxia and hypercapnia will be blunted in elderly patients. Anesthesia implications. Educate older patients for deep breathing and coughing reflexes preoperatively. Pre-oxygenate for prolonged period. Edentulous of elderly patient may be difficult to ventilate with bag and mask. There will be a decrease in protective laryngeal reflex, which increase the risk of aspiration. We should avoid or reduce the dose of opioids, which causes prolonged respiratory depression activities. Coming to hepatic function. Liver tissue mass decreased about 40% by the age of 80 years, and hepatic blood flow is proportionately decreased. Catalytic enzyme activity decreased. Synthesis of protein binding and coagulation factors also decrease. Anesthesia implications. There will be a decrease in metabolism of the drug and increase higher free drug levels. And elderly patient exhibit decreased immune responsiveness. Coming to renal function. there will be decreased renal blood flow, which causes decreased GFR, decreased renal plasma flow. And there will be a decrease in renal mass and decrease in tubular function, which leads to impaired sodium handling, decreased concentrating ability, decreased diluting ability, impaired fluid handling, and decreased drug excretion. Anesthesia implication of renal physiological changes. Age-related renal changes interfere with the excretion of anesthetic drugs. These patients are more prone to dehydration and fluid overload due to impaired tubular handling and renin angiotensin system. And these patients are more prone to electrolyte imbalance because of common use of diuretics. These patients should be catheterized in major surgeries. And these patients more prone for AKI when exposed to nephrotoxic drugs. Metabolism or pharmacokinetics. With increasing age, there will be a decrease in basal metabolic rate and heat production. So these patients are higher risk for intraoperative hypothermia. And intraoperative decrease in body temperature average almost 1 degree per hour. This leads to shivering, increased metabolic and oxygen demands, and risk of myocardial infarction. And with increasing age, there will be increase in body lipid content, which enlarges the volume of distribution of drugs. This may delay recovery in elderly patients. Protein binding. Circulating level of serum protein, especially albumin, is decreased. Qualitative change of serum protein reduces the binding effectiveness of the available protein. This leads to higher free drug levels and enhanced delivery of the drugs to the brain increased. Coming to nervous system, with increasing age, there will be a decrease in brain mass and a decrease cerebral blood flow up to 10 to 20% in proportion to neuronal loss. And there will be a decrease in synthesis of neurotransmitters. Anesthetic implications. MAC decreases by 4% per decade over the age of 40. Opioids are twice as potent in elderly. They will increase brain sensitivity because of increased brain sensitivity. Benzodiazepine should be avoided. They causes prolonged respiratory depression. BIS monitoring may be used to guide depth of anesthesia. These patients are more prone for postoperative cognitive dysfunction and delirium. Preoperative assessment. Pre-op assessment in elderly is very complex and sometimes difficult due to factors like frequent coexistence of multi-system diseases, heterogeneity of geriatric population requiring individualized approach for older patient undergoing surgery. Elderly patients are high incidence of mortality and morbidity because of the increased pre-existing diseases, decreased physiological reserve, and provider lack of knowledge. And coming to comprehensive geriatric assessment with history and examination, functional status, activities of daily living scale predict surgical complication. Complications have been found to be more frequent in inactive patient. And we should ask for the medication use and weight and nutrition, substance abuse. Laboratory testing should be guided by the patient history, physical examination, and surgical procedure. Frailty. Frailty is a syndrome of decreased physiological reserve and resistance to stresses. More vulnerable to poor health outcome, including falls, worsening mobility, ADL disability, hospitalization, and death. Frail scale. There are 5 components. If 3 to 5 is frail and 1 to 2 is pre-frail. Components are fatigue. If patient is having fatigue, easily fatigued, then count is 1. If patient is unable to climb 10 flight stairs, then resistant point is 1. And difficult to walk for long distance, then ambulation score is 1. If patient having more than or less than 5 comorbidities, depending upon the score will be 0 or 1. Weight loss more than 10% within 6 months, then score is 1. If score is 3 to 5, patient is frail. If it is 1 to 2, pre-frail. Cardiovascular disease and risk assessment. One is by revised Goldman cardiac risk assessment. There are 6 independent risk factors. These are: one is high risk surgery, ischemic heart disease, heart failure, cerebrovascular disease, insulin therapy, pre-op serum creatinine more than 2. If risk factor is 0, major complication rate is 0.4%. If risk factor is 1, major complication rate is 0.9. If risk factor 2, major complication rate is 7. If risk factor 3 or more, major complication rate is 11. A patient posted for non-cardiac surgery, known case of CAD, then we should assess the status of the surgery. If it is emergency, clinical risk transplantation should be done and proceed to surgery. If it is elective, then we should look for acute coronary syndrome. If patient is having acute coronary syndrome, then evaluate and treat according to GDMT. If patient doesn't have acute coronary syndrome, then we should estimate the perioperative risk of major adverse cardiac events. If patient is low risk, we can proceed to surgery. If patient having elevated risk, then we should look for MET score. If MET score more than 10 or more than 4, we can proceed to surgery. If it's MET score less than 4, then we should advise pharmacological stress testing. If it is positive, we should consider as a ACS syndrome. If it is negative, we can go for minimally invasive surgeries. Pulmonary disease. Patient with active pulmonary disease should undergo preoperative management optimization. And risk factors for pulmonary complications includes obesity, inability to cough, smoking, history of lung disease, site of surgery. More complication when surgery is in upper abdomen close to the diaphragm. And prolonged duration of anesthesia is more than 3 hours. And repeat surgery within 1 year or respiratory infections. Renal diseases. Preoperative renal status is best universal predictor of post-op renal failure. Risk of renal deterioration post-op higher in patient with serum creatinine greater than 1.2 milligram per deciliter. And poor prognostic indicators are oliguria, urine sediment abnormalities, severity of renal failure. And medication. Medication associated with known adverse effects, if withdrawn appropriately, should be continued. Example, beta blockers. These are recommended in patient with high risk for cardiovascular disease. And clonidine. It will decrease the stress response to surgery. Calcium channel blockers, H2 proton pump inhibitors, thyroid drugs, inhaled beta agonist, and anticholinergic drugs should be continued. Medication that can increase surgical complication are not essential for short-term improvement should be withheld. Examples are AC inhibitors and angiotensin receptor blockers. These patients usually have intraoperative hypotensions and diuretics, which causes the hypovolemia, hypokalemia. And the theophylline should be discontinued before the surgery. Nutrition. If weight loss is more than 10% in 6 months and serum creatinine less than 3.5 milligram per deciliter, these are high risk for surgeries. Intraoperative management, pre-oxygenation. Desaturation occurs faster in older patients. A deep breath of 100% oxygen within 60 seconds with an oxygen flow 10 liters per minute. Induction of anesthesia. Use of aspiration prophylaxis and rapid sequence induction should be done. Concurrent use of propofol, midazolam, opioids increase the depth of anesthesia. Hypotension is very common in this patient. Peak effects of drug administered is delayed. Midazolam by 5 minutes, fentanyl by 6 to 8 minutes. Changes in pharmacology of specific drugs. Thiopental. Administration of IV barbiturate produce the peripheral vasodilatation with moderate BP decrease. With a decreased baroreceptor reflex and increased vascular wall rigidity, the drug may cause a dangerous drop in blood pressure. The thiopental dose requirement may be decreased 20 to 75% of young patients. Second, propofol. Propofol produces greater decrease in systolic blood pressure than thiopental. Injecting the propofol slowly with sufficient time can minimize the effect of cardiovascular depression. Studies show patient older than 80 exhibit less post-anesthetic mental impairment with propofol than other agents. Induction using 1.2 to 1.7 milligram per day per kg in the elderly. Muscle relaxant. Aging affect the neuromuscular junction in many ways. One is the distance of the junction will be increased, the number of acetylcholine vesicles will be decreased, and receptors of acetylcholine will be decreased, and sensitivity of acetylcholine receptors unchanged. Coming to depolarizing muscle relaxant succinylcholine. This agent is metabolized by pseudocholinesterase, which is not affected by the aging process. The response of succinylcholine is unaltered with aging. Coming to non-depolarizing muscle relaxant, long-acting agents like pancuronium will have prolonged neuromuscular effect, and intermediate-acting agents like vecuronium also have prolonged neuromuscular blocking effects. Atracurium, cisatracurium, it will not cause any further prolonged neuromuscular blockade. The use of intermediate-acting is prudent because of even the duration of one single dose of long-acting may be too prolonged for the planned surgery. Fewer dose of non-depolarizing muscle relaxant will be required. Opioids increase in potency for
వాయిస్ వినపడలేదు.
as fentanyl. Volatile agents, ventilation.
ఒకసారి మళ్ళీ రిపీట్ చేయవా? వాయిస్ వినపడలేదు.
Volatile agents, ventilation perfusion mismatch will decrease the rate of action. Sir, depolarizing, sir, muscle relaxant, opioids.
Opioids, sir.
Increase in potency of all fentanyl, or remifentanil were demonstrated in EEG studies. A reduction in dose in elderly would be recommended. Dose of fentanyl should be reduced to half to achieve same effect of the patient with young patient. And all fentanyl, same recommendation as fentanyl. Volatile agent, ventilation perfusion mismatch will decrease the rate of action. Recovery from anesthesia with a volatile agent may be prolonged because of an increased volume of distribution by increased body fat. The MAC of inhalational agent is reduced by 6% per decade of age over 40 years. The lower lipid solubility of sevoflurane and desflurane has advantage in the elderly. More rapid control of anesthetic depth than higher lipid soluble agents. And regional versus general anesthesia. Benefits of regional anesthesia in elderly patient. Effects of coagulation system by preventing post-op inhibition of fibrosis.
Thank you.
Of airway, and it decreases the risk of hypoxemia and aspiration. And opioid sparing effect also there. Neuroaxial block. Size of epidural space is reduced. Volume of CSF is decreased. So there will be increased level of block, and there will be increased permeability of dura. It causes the onset analgesia with epidural anesthesia is more rapid.
హలో గణపతి, వాయిస్ పోతుంది మధ్యలో చాలా సార్లు.
Post-op management. Patient oxygen level. Madam.
ఇందాక పాయింట్ కూడా వాయిస్ పోయింది, వినపడలేదు. అందరికి వినిపించిందో లేదో. మధ్య మధ్యలో వాయిస్ పోతుంది. రీజనల్ అనస్థీసియా మొదలు పెట్టినప్పుడు కూడా పోయింది.
యాక్చువల్లీ ల్యాప్టాప్ పనిచేయట్లేదు మేడం, ఎందుకు కనెక్ట్ అవ్వట్లేదు, మొబైల్ తోటి చేస్తున్నాను.
మరి ఎందుకు మధ్యలో వాయిస్ పోతుంది? మ్యూట్ అవుతుందా?
మొబైల్ వల్ల మేడం, మొబైల్ నెట్వర్క్ వల్ల.
రీజనల్ ది మొదలు పెట్టావు చూడు, అక్కడ నుండి చెప్పు.
Benefits of regional anesthesia: affects coagulation system by preventing post-op inhibition of fibrinolysis, which decrease the incidence of DVT or pulmonary embolism. And there will be a decrease in blood loss in lower extremity surgeries. And do not necessary to instrumentation of airways, which decrease the hypoxemia and aspiration risk. And there will be opioid sparing effect. Coming to neuraxial block, size of epidural space is reduced, volume of CSF is decreased. So this patient will have higher level of spinal or epidural blocks, and there will be increased permeability of dura. It causes the onset very rapid. Peripheral nerve blocks, decrease in conduction velocity of peripheral nerve due to decrease in intersquamous distance and decreased number of axons in peripheral nerves. Post-operative management. Patient should be maintain oxygen levels more than 94% in post-operative period. And post-operative analgesia, poor pain control can lead to slow recovery, life-threatening complications. Anesthetic paracetamol can be used, but should be avoided in more than 70 years of age because of renal dysfunction and suffered hemodynamic instability. Peripheral nerve blocks, when feasible, should be used. Hemodynamic changes in post-operative management. And hypovolemia. Heart rate may not be reliable indicator of hypovolemia in elderly due to reduced sympathetic receptors, decreased efficacy of baroreceptor reflexes, and administration of concomitant beta blockers, and hypotension may exit without tachycardia. Hypotension. It is safer to administer volume in small intermittent bolus doses, watching response of CVP, BP, and urine output. Arrhythmias. These may represent the disturbances due to pre-existing cardiac disease, hypokalemia, hypomagnesemia, hypocalcemia, hypoxia, or hypercarbia. They may indicate MI, especially if patient is having VPCs more than 5, biseminy, VT, heart blocks other than first degree. Hypothermia manifests as altered mental status, delayed recovery from anesthesia, slugging, deep tendon reflexes, slow respiratory pattern, metabolic disturbances, and coagulopathy. Management. For mild cases, warming with blankets and warm rooms. For severe cases, active warming with methods like use of IV fluid, surface warming with continuous core temperature monitoring. And post-operative cognitive disorders are delirium, which is present 10 to 15% of elderly patients after GA. Mild neurocognitive disorder like post-operative cognitive dysfunction, and dementia, which is rare. Coming to delirium. Delirium is a syndrome characterized by acute onset of variable and fluctuating changes in level of consciousness, accompanied by a range of other mental symptoms. Incidence 10% after major elective surgery, but higher after cardiac surgery. Risk and precipitating factors for delirium: cognitive impairment, depression, sleep deprivation, immobility, polypharmacia, pain, ICU admission, visual impairment, hearing impairment, and dehydration. Anesthetic interventions include correction of metabolic and electrolyte disorders, perioperative continuation of pharmacological therapy for neuropsychiatric disorders, avoiding triggering agents, or inadequate controlled pain. And post-operative cognitive dysfunction, short-term change preoperative cognitive impairment, depression, surgical procedures. Short-term cognitive dysfunction may be attributed to microemboli, hypoperfusion, systemic inflammatory response, anesthesia, depression, genetic factors. Post-operative cognitive decline after major non-cardiac surgery is reversible in most cases, but may persist in approximately 1% of patients. Long-term cognitive changes may be related to underlying cerebrovascular disease risk factors such as blood pressure, cholesterol, and diabetes. Thank you. Hello. Hello. Srikanth sir.
గణపతి
శ్రీకాంత్ ఇప్పుడు ఇన్ని చెప్పారు కదా శ్రీకాంత్, నీట్ గా క్లోరిడిన్ వాడతారు, అవి వాడతారు, ఇంట్రాపెయిన్ అని ఆ స్లైడ్ లో అన్ని మెడిసిన్స్ 4 మెడిసిన్స్ అవి ఏవేవి ఎవరెవరు వాడుతున్నారు? రామ్ ప్రసాద్ గారు మీరు మొదలెట్టండి.
వినిపిస్తుందా?
హలో
హలో సార్, రమణ ప్రసాద్
సార్ చెప్పండి సార్.
వినిపిస్తుంది సార్, అయిపోయింది సార్.
సార్ ఏసీ ఇన్హిబిటర్స్, రిసెప్టర్
సార్ వాయిస్
బ్లాకేజ్
వినిపిస్తుందా నాది?
వినిపిస్తుంది సార్.
హలో
హలో ఏసీ ఇన్హిబిటర్స్ ను రిసెప్టర్ బ్లాకేజ్ స్టాప్ చేయాలని చెప్పినట్టున్నారు మీరు బిఫోర్ అనస్థీషియా.
సార్,
కానీ ఇప్పుడు రీసెంట్ ట్రెండ్ అది స్టాప్ చేయలేక్కర్లేదు అన్నట్టుంది.
ఎస్ సార్.
ఏసీ ఇన్హిబిటర్స్, రిసెప్టర్ బ్లాకేజ్ డ్రగ్స్.
యాక్చువల్లీ పరాష్లో అయితే ఇచ్చాడు సార్. షుడ్ బి అంటే ఇంట్రా ఆపరేటివ్ హైపోటెన్షన్.
AC inhibitors should not be stopped, sir. Recent guidelines prakaram we can continue AC inhibitors.
శ్రీకాంత్ సార్, క్వశ్చన్స్
సార్ మాట్లాడుతున్నారు కదా అంత సార్.
సార్ వినిపించట్లేదు సార్ నాకు.
కాదు, ఓల్డ్ ఏజ్ లో ఈ ఆస్టియో ఆర్థరైటిస్, స్పాండలైటిక్ చేంజెస్ ఇవి కామన్ కదా, కాబట్టి స్పైనల్ ఇచ్చేటప్పుడు కూడా మిడ్ స్పైనల్ అప్రోచ్ డిఫికల్ట్, పారాస్పైనల్ అప్రోచ్ ఇస్ బెటర్ బికాస్ ఆఫ్ ది కాల్సిఫైడ్ లిగమెంట్స్. తర్వాత సర్వైకల్ రీజియన్ లో ఆస్టియో ఆర్థరైటిస్ కానీ అవి ఉంటే ఎక్స్టెన్షన్ ఫుల్ గా రాదు.
సార్
కాబట్టి
హెల్త్ ఇంటర్వెన్షన్
బూజీ అవి పెట్టుకొని చేయాలి ఇంట్యూబేషన్.
ఓకే సార్.
Most important, sir, continue.
VQ matching is best in which zone of the lung?
సార్ కొంచెం గట్టిగా చెప్పరా, రామ్ ప్రసాద్ గారు వినపట్లేదు.
Ventilation perfusion matching is best in which zone of the lung?
Lower zone, sir.
No.
Zone 3.
Zone 2.
Zone 2. Okay. Zone 2.
Generally, geriatric law, most important what we all forget is more of psychological counseling and preparation. So generally, we don't do that. So that's what I feel. We will see more and more of geriatric cases. Already we are seeing, so it will be going on to increase definitely.
Okay.
Most of the times we forget to adequately counsel and reassure the patient. So generally, andarki kavali, but more of in geriatric anesthesia, it carries more weight.
Okay.
Yeah. Also, the point you stressed upon pain relief is very important in that. possibility of cardiac events will be more without adequate pain.
Yes, sir.
సిఆర్పి కదా రాసింది. Most of the geriatric patients are edentulous. With
Nice.
edentulous patients, it is difficult to ventilate with mask.
Yes. Okay, sir.
Omkar, any inputs? అవును జయరామ్ అండి వచ్చాడు.
Most geriatric patients, lung reserves are very low. So, as said by Ganapati, post-operatively, you should supplement with oxygen and backup, propped up position.
ఓంకార్ ఏదో మెసేజ్ పెట్టాడు టెంపరేచర్ మానిటరింగ్.
సార్ హలో,
చాట్ లో టెంపరేచర్ మానిటరింగ్ అని మెసేజ్ పెట్టాడు ఓంకార్.
హలో
హలో
సార్ ఏం సార్?
టెంపరేచర్ మానిటరింగ్ హౌ డు యూ డూ అని మెసేజ్ పెట్టాడు.
టెంపరేచర్
ఈ ఓటీలో లైక్ ఫోర్త్ ఎయిర్ వార్మింగ్ అని బ్లాంకెట్స్ ఎన్ని ఓటీస్ లో ఉన్నాయి మన దగ్గర? కేర్ లో ఉండే ఉంటది, బయట ఎక్కడైనా పెర్సనల్ హాస్పిటల్స్ లో.
మా దగ్గర లేదు సార్.
యాక్చువల్లీ హెల్త్ సిటీలో ఉన్నప్పుడు ఉండేది, కార్డియాక్ కేసులు అవి ఉన్నాయి. ఇక్కడ లేదు ఏబీసీలో. యాక్చువల్గా ఒకటి ఏదో మంచి దేశీ వెర్షన్ ఒకటి చూసాం మొన్న నేను అరవింద్, కానీ చూడాలి హౌ ఫార్ ఇట్స్ ఎఫెక్టివ్ అని. హీటింగ్ బ్లాంకెట్స్ అమెజాన్ లో 800 కి అవైలబుల్.
సార్ మీరు మామూలుగా మీరు ఎప్పుడైనా మానిటర్ చేశారు సార్ హైపోథర్మియా ఓటీ సార్?
హైపోథర్మియా ఇన్ ద సెన్స్ ఆ టెంపరేచర్ పోతానే కదా, రొటీన్ టెంపరేచర్ పోతానే. సో వి సీ దట్ exposed area is very less. All those things should be taken care of. And spinal lo obviously due to that acceleration and all severing a temperature loss undedi. And orthopedic surgeries abu pre-op preparation time adi ekku kada. So entire limb gaani both lower limbs gaani ala ekku safe exposed ga undipotayi. So and also some plastic surgeries, grafts avi unnappudu 2-3 areas ala expose chesi unchuతారు. So in all these cases the possibility of hypothermia is more. Obviously delayed recovery lo it's one of the cause kada. It's either electrolyte imbalance, hypoglycemia or hypothermia. So all this.
What is the 1 liter of fluid iste maniki enta temperature tagguddi?
అంటే
గణపతి.
సార్
It depends on fluid.
నార్మల్ గా ఐవి ఫ్లూయిడ్స్ నార్మల్ రూమ్ టెంపరేచర్ ఉంటది కదా, ఎప్పుడు కూడా మామూలుగా ఉంటది కదా. సో ఇఫ్ యూ గివ్ 1 liter of fluid, what is the temperature reduction? డ్రాప్ ఎంత ఉంటుంది మీకు బయట మామూలుగా ఐసీలో ఎంత ఉంటుంది?
డ్రాప్ ఐసీ
నార్మల్ గా 1 hour లో 1 liter of fluid ఇస్తే నీకు ఇంట్రా 0.5 degrees centigrade ఉంటుంది, ఐసీయూలో 0.3 degrees centigrade తగ్గుద్ది.
ఓకే సార్.
సో యాజ్ ఎ కాంబినేషన్ ఆఫ్ యాజ్ లీథర్ ట్రైడ్ లాగా ఇప్పుడు శ్రీకాంత్ చెప్పాడు కదా, హైపోగ్లైసిమియా, హైపోథర్మియా, అసిడోసిస్ అండ్ డ్రగ్ ఇంట్రాక్షన్స్ కూడా, ఎందుకంటే డ్రగ్ వర్కింగ్ లెవెల్ తగ్గిపోతుంది నీకు డ్రగ్స్ ఇచ్చినప్పుడు ఐసీయూలో అంటే ఓటీలో. సో దీస్ ఆర్ ద థింగ్స్ ఆర్ పర్టికులర్ జీరియాట్రిక్ పేషెంట్స్ లో నువ్వు చెప్పినట్టుగా ఉండదు కదా. వాట్ ఈస్ ఆటోనమిక్ నర్వస్ సిస్టమ్ ఇన్వాల్వ్మెంట్ ఇన్ జీరియాట్రిక్స్?
There will be decrease in parasympathetic system and increase in sympathetic activity, but at receptor level there will be a decreased response to at receptor level, sir. So there will be decrease in finally sympathetic system also.
మనకు ఇండియాలో జీరియాట్రిక్ కేసెస్ కొంచెం తక్కువ కానీ, బట్ అంటే అవర్ ఏజ్ లిమిట్ కాంప్లికేషన్స్ కేసు రాణి మేడం లైన్ లో ఉంటున్నారు కదా. ద యూకే కేసెస్ మినిమం యావరేజ్ ఏజ్ విల్ బి 70 years ఉంటాయి, అంతే కదా మేడం?
Yes sir, and many trauma list
మినిమం 70 years నుంచి మొదలైపోతాయి. అండ్ మీరు చేసిన దాంట్లో 84 years అబవ్ వాళ్ళకి చేసే సర్జరీస్ అన్ని తక్కువ ఉంటాయి. అక్కడ మనం 70 years తర్వాత చేసే వాళ్ళు చాలా ఎక్కువ ఉంటాయి. So our geriatric issues are very important, and where frailty and fragility and lot of things are there. It's very, very important. Particularly position change, OT table, pressure sources, compressions, that is more common, particularly when the fat is not there, and for old geriatric patients very high.
Yes sir, particularly orthopedic patients వాళ్ళైతే 90 years 95 years old కూడా వస్తారు, and fragile and dehydrated. Most of the times they'll be living alone, so they in winter months they don't take any liquids at all, so by the time they come dehydrated, dyselectrolytemia, kind of altered sensorium or urinary infections, chest infections, ila annitto sir. So it takes time to optimize them before we could take for surgery. And as you all said, regional may be difficult, and GA will also be difficult intubation, difficult like drug assessment and giving the doses, and particularly above 80 years. Like you may just need 1/4 of your usual drug doses, and you have to be patient, but don't give too fast because they are not under yet. So like that, you have to be very careful, and you have to have plan A, B, C for any surgery, because regional may not be that easy, and intubation may not be that easy, and positioning is not that easy. And ophthalmic cases, many of them we see Parkinson's disease like that also, or COPD, very bad COPD. They'll be coughing and can't stay still for eye surgery. So though they can do under local blocks, but because of the because they can't stay still, you may have to give GA for them. So such cases also you'll have to think about GAs. So all these are the geriatric cases are more in Western countries, and with the weather conditions, they'll have a lot of added problems as well. Thank you. Thank you.
Thank you.
Thank you, ma'am. Thank you, Ganapati. And Srikanth, ఎందాకేదో చెప్పబోతున్నావు మళ్ళీ ఆపేసావు.
Oh, I forgot to say, we have to, many of them are on anticoagulants, acetone, or dual antiplatelets, or people may be on pacemakers, elderly people. So all these have to be optimized, or pacemaker people need to call the technicians and change. All these are there for geriatric cases. when a student has to write answer for geriatric patients, you have to write a lot, not just system-wise physiological changes, but you have to write all practical problems also and optimization. Thank you.
Thank you, madam. Anything else to add? Omkar, Sarath, Mehta ji sir, Shekhar.
ఓన్లీ థింగ్ ఇస్ పిఎస్సి లో ఒకసారి మళ్ళీ స్టూడెంట్స్ ను ఏమేమి యాక్చువల్ గా ముందు పిఎస్సి లో డ్రగ్స్ ఆపేయాలి, ఏది మళ్ళీ వాడాలి, ఒకసారి డిస్కస్ చేయరా?
Yeah, we are continuing all, sir, according to recent guidelines. Only OH, we will switch from oral hypoglycemics to insulin preoperatively, as per my knowledge.
Sir, that's a big topic, sir. That needs to be another class for that. You need to cover a lot of drugs. That's why it's a big topic.
Yeah, అలాగే యాంటీప్లేట్లెట్స్ అండ్ ఎసిట్రామ్ ఇవన్నీ కూడా ఉన్నాయి కదా చేంజ్ చేయాల్సినవి, అండ్ బ్రిడ్జింగ్
Yes, madam.
థెరపీ.
We have a long list of drugs.
Yeah. I think one class should be patients on anticoagulants, antiplatelet therapy మీద ఉన్నవాళ్ళు, how do we manage అలాంటి క్లాస్ ఉంటే బెటర్.
Yes, madam. That's better. So that the focus will be on the particular drug, when to stop and when to continue post-operatively.
Also, complete newer anticoagulants separate ga oka topic annatunna.
Yes. And one thing for all the students who join new, welcome to Morton. And these cases, and we are discussing here, these classes are to make you more self-sufficient, not to scare you with all these things. You have to keep in mind before going for a surgery or a geriatric patient. You have to keep in mind all these things, but that doesn't mean it should scare you. It is scary, a bit scary, but you have to deal with it.
Oh, I forgot to tell yesterday, new students approached me that they are not in Morton group. Who's the admin people? Please join them so that they'll get all these classes information. Hello, Mohan sir.
చెప్పండి మేడం.
అడ్మిన్ ఎవరో మోర్టన్ గ్రూప్ లో న్యూ స్టూడెంట్స్ వాళ్ళందరి లేదంట. దే ఆర్ నాట్ గెటింగ్ ఇన్ఫర్మేషన్ అబౌట్ ద క్లాసెస్ అండ్ అదర్ థింగ్స్ అని చెప్పి ఎస్టర్డే దే టోల్డ్ మీ. సో
ఒక నిమిషం, మీరు అడ్మిన్ కదా, మీరు జాయిన్ చేయొచ్చు కదా.
మోర్టన్ లో అడ్మిన్ నేను కాదనుకుంటా సార్. ఎవరున్నారో చూడండి.
చూసుకోండి, మీరు అడ్మిన్
కాదు. సరే చూస్తాను.
మీరు అడ్మిన్, మీరు యాడ్ చేయండి.
థ్యాంక్ యూ.
Okay, Ganapati, thank you, sir.
Thank you, sir.
Thank you, Srikanth. Thank you, Ganapati.
Thank you, sir.
Thank you, Ganapati. Good talk.
Thank you, sir. Thank you, sir.